This is a really good group of people coming out in a rain. So thank you so much for coming. My name is Rachel Katie. I'm one of the OBGYNs in Crosby, and I'm joined this evening by Melissa Goebel, a women's health nurse practitioner, Donna Claypool, and Dr. Christina Kramer. And we, about a year or so ago, we kind of took on menopause medicine just as a special interest of ours, and we've done some additional training and have really wanted to do some community events. I'm not trying to sell anything, but really is trying to provide some information to the community. So this is a casual talk. While we're talking, please come up and, if you need to go to the bathroom, go to the bathroom back here. Do not wait on our behalf, and food and whatever. A big shout out to the staff here and the owners. Thank you guys.
Thank you guys.
They're here to learn all about menopause stuff. It's going to be amazing. And then also to our marketing department, and of course Dan the man videographer. So thank you for coming here. So this evening our talk is divided into three main parts. And if you can't hear me, just whatever, again, casual, comfortable, bathrooms, food, tab. And so we're going to be talking about just three parts. Melissa's going to be visiting with you about a brief overview of some of the kind of common symptoms that bring people into clinic as far as for menopause type symptoms / midlife. I get the wonderful honor of talking about weight gain in midlife, for which I know of what I speak. And then Dr. Kramer is going to be talking about some gynecologic cancers as far as some of the symptoms to watch for, why you still need to come in to see a clinician for some screening. And afterwards, we have some of our oncology department here, as well as Heather Erickson. Shout out to Heather for dietitian to add to the fun information. So, and we'll be staying after to address any questions and one-on-one discussion. And thank you again sincerely for being here. It would have been really, as we were driving here, I'm like, nobody's coming. So you have my heart. So thank you so much. So without further ado, we'll just get started. And again, happy to answer any questions at the end. Yeah. So thank you.
All right. Thanks again for coming. My name is Melissa. And again, I'll just kind of talk about some overviews with menopause. This is all of our providers. Dr. Mike and Rachel Katie, Dr. Kramer, and then Donna and I are both women's health nurse practitioners. Our mission statement, basically we're just kind of coming in trying to bring women back, and our goal is to make it kind of a one-stop shop for you guys. So you can come in, you can get your mammograms, your pap smears, your labs and everything kind of all under one roof, colonoscopies if need be, and all that fun stuff that goes along with age. So some of the objectives, like I said, we'll do overview of menopause, some weight gain, and then also some gynecological cancers. What to expect? Everyone transitions through menopause at a different time and a different way. Your mom may say, oh, I breezed through it, and you might have the worst hot flashes ever. It kind of just depends on everybody, and so nobody transitions exactly the same way through menopause, and that's why we're here to individually treat each person. Symptoms, some of the symptoms that you have during menopause are what brings you back into the healthcare. You probably had your babies and then kind of like put yourself on the back burner because you're raising children, you're taking care of family, kind of that sandwich generation where you have your parents and then also your children to take care of. And once you hit menopause, the symptoms bring you back into the healthcare system. It is a natural stage of life. Some patients think of it as a disease. It is not. We present, naturally through it. So extra help to transition is not a sign of weakness. Just because you come in seek help to transition through menopause does not mean that it's weak. It's a weakness. So many menopausal symptoms interfere with the women's ability to function in their full ability. Night sweats, hot flashes, all that stuff. So then you're deprived in sleep, but then we have mood changes because we're tired, we're exhausted, and we can't function to our full ability. Common quality of life issues, like I said, hot flashes, the weight gain, which helps which changes our perspective on ourselves, and we don't feel as good about ourselves, so we don't want to go out in public, we don't want to do this or that. Osteoporosis is another big one. We are more at risk as we transition when we have a loss of estrogen, cancer, low libido, sleep disturbances, integrative medicine. Many treatment options also prevent the care that exists for women so we do not have to suffer. So coming back in and kind of going through what can we talk about? Low libido, you know, that's a huge relationship issue as well between our spouses and partners and ourselves. But if we gain weight, then we don't feel as good about ourselves, so we don't want to initiate that. Hot flashes. Many women have hot flashes as we transition through menopause. There's a lot of options when it comes through to hot flashes. One of the new ones is the lavender sticks that each of you should have gotten in your little bags. It's a trial thing. Lavender is proven to help kind of with the hot flashes, slow them down, and so we use that. Hormone therapy is another big one that can help women transition through hot flashes. When we replace some of those hormones that estrogen, you know, gives decrease, and so therefore we kind of replace it back when you're starting to have hot flashes and they keep you up at night. So hopefully if we can control them, you're going to get better sleep as well. New data shows that decreased diabetes, improved heart health, decreased mortality, and for estrogen alone, replacement therapy is a decreased risk for breast cancer. So the whole Women's Health Initiative kind of came to an abrupt stop back in 2002 where they said no hormone replacement for women, but now we're finding out that it is okay to replace women. We have to look at when you're going through menopause, how far past menopause are you, and some of your other risk factors that go along with it. NAMS is our National American Society, Menopausal Society, and they are who we kind of base off and look and get our data from. And so their position statement attributed the risk of breast cancer in women on an estrogen progesterone therapy is slightly greater than the observed with the 1 daily glass of wine, but is less than 2 glasses of a daily wine. And it's also similar to the risk reported with obesity, low physical activity, and other medicines. So you can see that they looked at how many women, is it 10,000, right? 10,000 women, and there was eight women more had an increased risk of breast cancer with the estrogen. So there are options for those that have contraindications like Biax and Duave. So if you have a contraindication, like say you have breast cancer and you're not supposed to have it, it was an estrogen receptor, there are other options as well for hot flashes and night sweats and stuff for women who are experiencing that. Osteoporosis is a big common factor that happens when we transition through menopause because of the loss of estrogen and the protection to the bone. More than 1/4 of women with a hip fracture will die within 12 months. That's pretty amazing. Yeah. So when we kind of think about that, what can we do to help prevent osteoporosis? Calcium, vitamin D, getting your DEXA scans. For patients who have a higher risk, then we will start like a medication earlier to try and prevent the osteoporosis. It's the most common cause of morbidity in menopausal patients. And if you think about it, our urinary symptoms increase, so therefore we're at an increased risk of falling and getting a hip fracture because we're getting up more at night and tripping and falling as well. The WHO recommends to start the treatment to prevent fractures if a DEXA reading is in the osteoporosis range, even though most fractures occur in the osteopenic range. So osteoporosis means that you have the bone damage. Osteopenic is when you actually have a thinning of the bones. When to start screening, the recommendation is at 65. Otherwise, it is earlier for patients who have risk factors. So if you have lost 1.5 inches in your height, it is associated with a lot of vertebral fractures. Then we would move forward with a DEXA scan if you had lost, and you're 55 and something like that, and you've lost height, 1.5 inches in your height. Then we would move forward with a DEXA scan because that is one sign of a vertebral fracture. FRAX score is recommended to assess the need for treatment. That's where we look at patients' risk factors, and we can calculate that in the clinic when you come in to see us. It takes into account where you live, your height, your weight, history of a fracture, if you've had any type of fracture, your wrist fracture, bone fracture, any type. Current smoker, rheumatoid arthritis, secondary osteoporosis, and then alcohol if you drink 3 or more drinks a day. This is an absolute risk of hip fracture and a major osteoporotic fracture. So if the 10-year absolute risk is 3% or higher, or a major osteoporotic risk is 20% or higher, then we would start some medications, one of them being a bisphosphonate, like a raloxifene, to help so that you don't have any more bone loss. By 2020, 12.3 million people in the US will have osteoporosis. So it's only 1 year away. That's a lot of women. Another typical kind of sign and symptom of menopause is called vaginal dryness. As we transition through menopause, our vaginal pH increases, and so therefore we're at more risk for any infections. Our tissues become thinner, and our normal flora is replaced by other floras, like a different type of bacterial, and so therefore we're at higher risk for the infections. Symptoms are itching, burning, pain with intercourse, it can be, which are all associated with the decreased estrogen as well. Affects 50% of postmenopausal women and even higher in women with breast cancer. Treatment options for vaginal dryness would include vaginal lubricants, a vaginal moisturizer, lidocaine. We do use local estrogen even in patients who have had breast cancer. We usually talk to their oncologists, and most of the time it is okay to use vaginal estrogen with patients who have had breast cancer because it's localized. It doesn't get absorbed systemically into your system compared to like an oral contraceptive pill or replacing estrogen orally. It stays local to the vagina. Ospemifene, DHEA, and then there's also a laser treatment that we can use. It's called the DIVA, and that also has been shown to be helpful for vaginal dryness and painful intercourse. It's a 3 series of a treatment with the vaginal laser, and that's done at Dr. Waters' office, but we do go over there and do them. Painful intercourses, reasons related to what we call genitourinary syndrome of menopause, or GSM. And basically that is the low estrogen, again, in the vagina. And so management would be careful exams by your provider. Sexual concerns will be addressed by a multi-specialty approach, and like physical therapy, we have sex therapists, pharmaceuticals, and also members of the society. Female sexual dysfunction. Women we don't want to be labeled dysfunctional. We don't want that. But a lot of times it gets labeled as the female sexual dysfunction, just like men have erectile dysfunctions. It's a very common issue, and it is physiologically normal. A lot of this is due to the hormones and neurotransmitters in our brains. Only 3% of the women will actually self-report it because it's one of those things, if you don't get asked it, a lot of times you're not going to bring it up to your provider either. So no orgasm, pain with intercourse, no pleasure, you get anxious about this, you have trouble with lubrication because of the vaginal dryness with low estrogen. So we do have options for that as well. Usually we're pretty good about, I feel like, asking about it, but don't be afraid to bring it up to your provider because you're definitely not the only one out there. And cancer and sexuality. Advances in medical science have greatly improved with the treatments and outlook for cancer, or women with cancer. We're living longer as well, and so we need to have options for this population of women as well. 1 in 3 women will be diagnosed with cancer in their lifetime. As we age and get older, our chance of getting cancer increases just naturally because of age. So many cancer treatments have a direct effect on women's sexuality. And then asking about pain and sexual function is also important. It's a huge quality of life for a lot of women, and even as we get older, you know, people say, oh, I gave that up a long time ago just because of different options. That's not the case anymore, and I feel like we're doing a better job of it, and you shouldn't have to give it up because it is an important part of your relationship, and there is a lot to offer for it.
So does anybody know the fastest growing group within our population, like fastest growing segment of the population? And that's actually postmenopausal women, all right? So the average age of menopause is 51 in the United States, and that's the fastest growing segment of the population. It's also the least studied segment of the population. And so that was honestly part of the reason why we kind of wanted to delve deeper into our own training into menopause medicine, because it's an area of extreme shortage of clinicians, all right? And actually recently the AARP had a big article that came out citing the same thing. You know, people that actually specialize in menopause medicine, huge shortage of that. And to be honest with you, this is not stuff that we're trained on in residency or in medical school. So it really kind of becomes like, got to kind of really seek it out on your own and your own certification, if you will. And so this is the bulk of our population. This is also a very large part of my practice, for which I'm thankful. Turns out a lot of us in midlife, myself included, notice some weight gain. I don't remember the last time I saw a patient in midlife that came in like, I can't believe how happy I am with my weight, or like, I can't believe how much I can eat and not lose weight. It's never happened. I venture to say it'll probably never happen. So, and just as a OBGYN, just as far as asking, like, why is that? And I found the answers to really be subpar. Like, it's hormonal. What does that mean? It's just part of, it's hormonal. It happens to everybody. Those are not good answers, okay? So I will say that this is just a 15-minute quick talk, but trying to provide just a little brief insight into some of the more up-to-date information, some of which might be very well familiar to you. And again, Heather Erickson, who's a dietitian who knows a lot more than I do about this, but it is its own segment of medicine, and it's a massive, no pun intended, part of midlife postmenopausal care for patients, obviously for men as well, but just focusing on that. So I just want to briefly talk about what do we have control over, what's the biology behind obesity, weight gain in midlife, and what are some treatments? What can we do about it? Or are we just going to, have pizza and some beer, which I'm totally fine to have, and you can do that. You can do that with some carrots. Anyway, I have had all of it. So anyway, we have to be real, right? We're on the clock. We got to be real. So some of you might have heard of your BMI, or that's body mass index, and a quick way to figure out somebody's body mass index is just on Google. There's easy, you put in everybody knows their weight in pounds, more or less, and then you put in your height, and it'll give it to you in kilograms per meter squared. This is defined, this is meant to say class 3, not class 4, but as far as mild, moderate, and severe obesity, and I will tell you, it's pretty hard to stay in that normal ideal body weight, but this is a guideline, okay, and this should be a goal, all right. So when you go into a clinic, they should automatically now on health records, it calculates your body mass index, for better or for worse, unless you decline to be weighed, which no judgment, okay. So the big question, why is there weight gain in midlife and after? Why does that start? And the typical scenario that people will say is, I didn't even used to have to really pay attention to my weight, then all of a sudden I feel like no matter what I do, I'm gaining weight. And what is that? And so kind of just starting with a little bit of biology, and we'll move on from there. So it's actually our central nervous system, meaning our brain, that controls our weight. And our brain is being bombarded by hormonal signals. I just mentioned a couple of them, but it's from our stomach, our large intestines, our pancreas, liver. It's all giving and actually very importantly, our fat tissue actually makes hormonal signals to our brain. Now there's a couple different brain pathways. Some of us are more genetically blessed and this is important, and we should do a better job of asking this about, we ask about family history of diabetes and colon cancer and all that, but we should also ask about family history of obesity, because some people do have that pathway where it's harder for them to be satisfied, they're hungry more. And then there's actually a brain pathway where they get full more easily, and that's just, a blessing or curse depending on their genetics. So that's part of it. But one of the hormones in particular, leptin, which comes from our stomach, we want that level to be high. That makes us feel satisfied. It increases our satiety, like I'm good, all right, I'm good. So a lot of this really is more hormonal. It's a signals to our brain if we're hungry, or what we, anorexigenic, meaning hungry or satisfied, all right? Estrogen actually is our friend in the sense that it actually increases metabolism. It increases metabolism. A lot of people don't know that. So decreased estrogen which occurs with menopause because our ovaries aren't making as much estrogen. That level goes down. And what happens is a decreased ratio of like less muscle and more subcutaneous fat, all right? That's what happens. And so this is not an indication for hormone replacement therapy. I'll talk about this briefly, but hormone replacement therapy can actually help women kind of lose weight a little bit. It is not a weight loss drug. It is not an indication, but I'm just saying that that's kind of how it works. Men and women, we all see this in our day-to-day life, have different fat distributions. Men tend to have it more in their gut, right? And that's why you'll have, a 30-some-year-old with a big gut. Women, premenopausal women tend to have their fat in their buttocks and their thighs, all right? And actually what's kind of interesting is that fat is different. Those fat cells are different when you look at it under a microscope. And it's then the kind that's in our gut, meaning in between our organs, like in our intestines, and also the kind under our skin, our subcutaneous kind of skin fat, where you kind of push it, it's like it's right there. That fat is not good, okay? I mean, no fat's, it's like we don't like any of it really, but that fat is harder to lose. It actually, and I'm gonna show one little image here in a second, but it's actually a real fibrous type fat. It's harder to lose with diet alone. That's when like that exercise part really comes in. It increases inflammation and decreases metabolism by decreasing some of those signals to our brain saying, hey, I'm good, I'm full, I don't need to eat more pizza or whatever. But by the way, please eat it because we have some. And so take a plate home. So the fat, in contrast, the fat that women have in their buttock and their thighs, that's more that gynecoid distribution, that's actually a better fat to have. It's an easier fat to help as far as if somebody wants to lose it. It's an easier fat to shed. It also promotes metabolism, all right? So that's kind of an interesting thing. I don't think that's really out there. So what happens, my last point, what happens with menopause is that your estrogen levels go down. Fat does not deposit in your buttock and thighs as much. It deposits here. So even for women that are like, I'm not gaining weight, maybe they're real fitness gurus, I don't care. They're gonna say, my pants just don't fit as well. It's like it just feels different. It feels like thicker, they'll say. It's like, that's because it is, all right? That decreased estrogen, which we all have with perimenopause, menopause, all right? So it's kind of the perfect storm, meaning there's more bad fat distribution with decreased estrogen, meaning more of that subcutaneous, or what we call visceral fat. This increases our waistline and lean muscle to fat ratio changes. Can I get an amen? Amen. Amen. All right, so I heard that at a time. I'm like, I love that. So I'm like, yay. The other thing too, when I say it's a perfect storm, most women, not everybody, it's kind of like talking about somebody's life journey, or for some women, their pregnancies, that it's not all the same for everybody. But for most women, their circadian rhythms, meaning how well they sleep or whatever, is not going to be nearly as good, okay? It's just not going to be as good. And sometimes that's from hot flashes, sometimes it's from other issues, all right? And hey. Also, what's kind of interesting is that poor sleep, I mentioned that hormone level, that leptin, which makes our brain feel full. It's like, we're good, we're full, we don't need any more stuff. Poor sleep actually decreases our leptin. So you're hungry if you're kind of chronically fatigued. You're hungry and you're not going to go for a carrot. You're going to go for some awesome added sugar. This is what's going to happen, all right, unless you're a supreme being. All right, so women in midlife often start medications. That's what, they might be diagnosed with something for the first time. They haven't been into the clinic since they were, maybe if they had children, that might have been the last time they're in the clinic, and it's 20 years later, and they're like, oh, by the way, you have high blood pressure, guess what, good for you, you've got high cholesterol, all this kind of stuff. And when you look at the whole list of medications that actually promote weight gain, it's a lot, okay, it's a lot, or steroids or whatever. So this is kind of a perfect time, we get lower estrogen, we get our fat deposit where it's harder to lose, decreased metabolism, poorer sleep, and sometimes medications. Obviously each woman is different, but just sort of broadly speaking, okay? So I mentioned some of this biology because I don't want people to feel like they're broken or there's something wrong with them, all right? I think sometimes at least kind of having an explanation maybe kind of helps people. I don't know, for me it kind of helps instead of feeling like all this hairy is happening and you have no idea why, okay? So again, every day I'm eating the same, so why am I gaining weight? That is every day. And people feel like you don't believe them, but I obviously believe, like, why would you, yes, that's true. One of the biggest things that we can do, and we've done a really bad job of this, is like think about all the stupid stuff that you hear all day long, and like all the misinformation and whatever. And what nobody tells you is what really is starting to come out there now, is that your metabolism decreases with menopause by about 25%. So when you're in your 40s, you better start planning ahead. It's like, well, I'm still, cycling and whatever. It's like, good for you. But it's coming, or whatever, okay? That's, whatever. And so why doesn't anybody tell you that? Like, nobody in medical school tells you that, whatever. So it's not, it's really like all of a sudden, and you feel like you're kind of in this tailspin. That is what happens. So you have to plan for that, okay? You have to plan for that. So if somebody just tells you, like, hey, this is gonna happen, it's like, okay, at least I know. So somehow you need to plan on about anywhere from 400, some people say up to 600 calorie a day sort of compromise. They're either eating less or you're doing something, all right? So yes, if you're eating the same, you will gain weight. That's just what it is, all right? And if you're doing the same stuff, you will gain weight. I don't know anybody that didn't share that memo with me a while ago, but that's the truth, all right? So there you go. So what can we do? And again, I mentioned how common this is. I'll talk about that here in a second. But I think the first thing is be prepared. At least that this is going to happen. We prepare ourselves for all sorts of crazy other things. Consider estrogen. Again, there's some real indications for that. It has been villainized. It is not for everybody. Again, I started this by saying we're not here to sell you anything. But I'm also here to at least hopefully provide some accurate information. And I would encourage people to look at the Women's Health Initiative website. The average age of those women were in their mid-60s, and it was a certain type of estrogen and progesterone that really is felt to be worse for blood clots and those kind of things. It is not for everybody. Also, we have Heather here to talk about this later, but IBT is intensive behavioral therapy. So insurance companies are covering a lot more dietitian consults. People feel like, and this is often the case, where it's like, well, maybe a dietitian consult for you because this is a disease. This is a disease, being overweight or obese. And it's like, no, I know what to do. And that is just not true. I mean, I think we all can learn stuff. And if not, definitely in the minority. Eating whole foods, you're hearing more and more about that. We'll kind of come into that here in a second. Also, higher fiber. Heather mentioned this before this talk, because that also sends a hormone to your brain that promotes satiety, meaning you feel full. And we don't talk about this a lot, but there is a role for weight loss medications. And everybody has Fen in mind from the 90s, but there are a number of medications that are better studied. And if you're talking about something as severely concerning as different levels of obesity, it's something to consider. We medicate for a lot less. Not everybody needs it, but it's out there. And in some case, weight loss surgery. And also to get help with your sleep. Sleep apnea, enormously common. Huge risk factor for heart disease. Nobody really thinks about that. But also it's just exhausting to feel exhausted all the time. Those are not like the funnest people to be around, and they don't even like themselves. I get it. Visceral fat, that fat in between your organs, is harder to lose, okay? This is when exercise comes into place. This is the harder fat to lose with just diet alone, okay? That's why we really, really, really stress, and we have some information on this in the back, but that weight-bearing exercises, we always talk about cardio, but weight-bearing exercise is really the main thing that you can do to increase your muscle mass. And what does that do? That increases your metabolism. And women are worried about bulking up with weight-bearing exercises. That's incredibly hard to do, okay? So that's incredibly hard to do. So actually we have some recommendations back there as far as exercise recommendations for older adults is how it's worded. I'm like, oh gosh. But cardio is part of it, but the weight-bearing exercise is certainly way more important than I ever realized as far as what's actually recommended. It's a lot. That's the only thing that's going to increase your muscle mass, and it's an easy relatively easy thing and sometimes kind of a fun thing to do to increase your metabolism so you can figure out that 400 calorie a day problem, right? That's what you do. So this is such a beautiful slide. But anyway, all it's saying is that fat in our butt, leg region increases estrogen. It's beneficial for metabolic rate or burning of calories, decreases inflammation, and it decreases our heart metabolism problem risk. Whereas this fat, I don't have a pointer, but this fat here and in between our organs does the exact opposite. It's very pro-inflammatory and is very bad for our heart and very bad for our metabolism. So there you have it. Okay. Yes, weight gain can be due to aging and lifestyle. Most women, when they go through menopause, gain about 5 pounds instantly type thing, and then about 1 to 2 pounds a year. So you figure over 10 to 20 years, that really adds up. So we're living longer. The average woman's living into her mid-80s, but we're also living bigger, right? I mean, I think we can all walk around and see that at any point. I think the next 3 points are important to read, actually the next 4. 60% of women aged 40 to 59 are overweight. That's that BMI category thing. 73% of women 60 and over are overweight, okay? And then 35% of women are obese. Moderate obesity, that's that class 2 obesity, again by our BMI, decreases our lifespan by 3 years. And extreme obesity, which really is not that extreme when you're looking around at the general population, it decreases our lifespan by 6.5 to almost 14 years. Again, so we medicate for way less than that, you know? So it's not that everybody needs medications, but it is important. So those were statistics that I was frankly kind of surprised on. And again, weight loss is not impossible. Yes, it gets a little bit harder, but it is not impossible. And also being overweight, like insulin is a really good thing to have. Insulin made by our pancreas, it makes us feel full. So when we get overweight, we get insulin resistant. It's harder to lose that weight. It's more pro-inflammatory. It's harder to lose that weight. It's harder to feel satisfied, all right? So yet another reason that we need to think about this. Metabolic syndrome is something that affects about 1/4 of the population. These are some of the criteria here, basically kind of the pre-diabetes stuff, high blood pressure, a waist of 35 or greater, low HDL, which HDL is your good cholesterol. You want it to be high in women. 50, anything less than 50 is concerning, okay? That's a repeat, sorry. This is an important thing, and this is why I think a lot of people do need to have a consult with a dietitian, if not everybody. And again, a lot of times insurance is covering this, particularly that intensive behavioral therapy, IBT. So 57% of people think it's hard to know if something's healthy. I'm surprised it's not 90% of people, or 100% of people. The average new food item, if you read the labels, will have 3 claims, like low fat or, probiotic or whole wheat or whatever. Like it's, what's what. It's really hard to sort through that stuff. That's the average new food product. And people make their decision. I mean, our food market's been hijacked. I don't need to preach about that. Like everything's refined and what the government pays for. It's hard to, it's more expensive. It takes a little bit more planning to eat healthy. It takes a little bit more planning to eat whole foods. But when you're driving your car and you see that a gallon of gas costs whatever, $3, you don't say, oh, it's too much. I'm just gonna put a liter of Mountain Dew in there or whatever. It's not gonna run, and that's what that means, like crap in, crap out, and so same thing for us, like our fuel needs to be whole foods, okay? And believe me, I break the rules. This is like, I know the stuff, but a lot of this tastes really good. Okay, so we have to get smaller plates. Back a few decades ago, a dinner plate was a lot smaller, it was like 9 inches, and now it's like a platter, all right? So I do think that that's helpful. And also to question your clinicians, because it really is its own area of medicine. You have to really question as far as to really try to find the information, which is why it is helpful to go to people like Heather for a little bit. Consider the source of information and always question, all right? Because there's a lot of crap out there. Also, your basal metabolic rate. This isn't exactly always accurate, but this is another computer thing too, where you can put in your age, your height, your weight, and it'll give you like about what your body burns in a typical day, just kind of a ballpark. And you can fool around with that, like what it is from a 20-year-old to an 80-year-old, and it's, you know, but it's something that at least gives people a little bit of a guideline. So let's talk about just normal things as far as, I have to hurry for Christina to talk. But in our midlife and menopause, we have to think about that some things, vitamin B12, for example, which is really important for some of our blood production, that absorption gets a little bit less. So we want to kind of consider what our vitamin B12 level is and think about that with our food intake. Folic acid is also important. We talk about calcium for healthy bones, but vitamin D is the car that gets the calcium where it needs to go. And it's not just in our bones, it's also in our muscles. It's in our muscles. You know, you think about drinking a warm glass of milk at night if you have, you know, achy, restless leg type stuff. Meal planning, not eating when you're hungry, substituting spices for salts, just little things like that. The omega-3 is important as well. And most things really come in just a multivitamin tablet. You don't need to overload your cabinet with insane amounts of supplements, okay? I think as far as our lifestyle and behavioral modification, the next few slides really basically just focus on trying to find your why, and also a little bit more of a positive angle on things as far as like what you get to do instead of what you have to do. You know, it's like if somebody wants to succeed, they need to visualize what success looks like instead of visualize what failure looks like, right? So so our weight is a cornerstone of our success, and your lifestyle, behaviors, and happiness to a large extent do depend on your weight. All right, and just kind of briefly to think about weight loss typically is more of a short-term type thing. Most weight loss for people that are really bent on losing weight occurs within 4 to 6 months, whereas health maintenance is more of a longer-term type thing. All right. So in the real world, what do? You eat breakfast every day, physical activity, reduced bad fat intake. There's some really good fats out there. Self-monitoring of your diet, watching less than 10 hours of TV a week, or iPhone a week, or whatever, I guess. And when you think about it, when you screen, like this was from a larger population, only 2.7% of adults actually met those criteria. So some of it is we know what to do, some of it is we don't know what to do. And again, information is power. You have to find your why. So again, what I was mentioning, what you get to do, that you do have the power to change, expecting success instead of failure. This is like letting yourself not be your worst enemy. Finding what your why is. Like, why do you want to be at a normal weight? Why do you want to be at a normal BMI? Like, why? And I think, you know, that's a little bit of a bigger, more personal question. That's kind of the big thing. It's important for long-term success to make it as easy as possible and to use the least amount of willpower, meaning obvious things like what you actually enjoy, what brings you joy, bringing out all distractions from your day-to-day life, you know, bad, tempting things, keeping it out of your way. All right. Thank you very much.
This is, like Rachel said, really informal, so please interrupt if something I'm saying doesn't make sense or if we kind of want to tackle a different cancer topic. And I know that, you know, cancer is one of those things that everyone in this room has been touched by in one way or another, either personally, you yourself, or a family member. And the reason that we wanted to talk about gynecological cancers is, I mean, I think you're getting kind of a common theme that there's just a window where women kind of disappear from care as you're caring for family members, parents, children, and kind of put yourself on the back burner. I've also had patients come in telling me, you know, well, my other doctor said I don't need to see anyone anymore, or no one's done a pelvic exam in 30 years. And I guess my argument to that would be that's why we still have a job, is hopefully when we're skilled at it and it's not like a horribly traumatizing experience. But two, that there's some preventative measures that we can talk about when you're in the office to hopefully allay some fears. So We're going to talk about some theories on the origins of some common gynecologic malignancies or cancers, talk about how do we detect them, how do we treat them, how do we prevent them, and then talk about screening options. Be smarter than I think. Okay, so the first one we're going to talk about is cervical, and these four, there's also, fallopian tube, vaginal cancers, other things like that. Just looking at these big four here, and this is something that I commonly get to talk to women about in the office. Not all cancers have like a strong genetic component. Now, ovarian, endometrial, those are two huge exceptions. There are a lot of genetic conditions that can increase a woman's risk of having these malignancies. And sometimes it may not be exactly obvious, particularly if you have a lot of male relatives, frankly, because obviously they're not going to have endometrial or ovarian cancer, but they may present with prostate cancer, brain cancer, colorectal cancer. But that would be an important part of our history taking as family history. Now, cervical and vulvar, we're going to get to those here in a second, but those don't typically have a high genetic predisposition. Those have a lot of risk factors that are either behavioral or potentially acquired, which you'll see in a second. So this is the list of cancers in women from 2018 in incidence. So breast, lung, colon, endometrium, thyroid. So as far as the gynecological, endometrium is the same incidence as colorectal. Ovarian, as far as incidence, is much farther down. And then cervical is much farther down at number 13. But as you'll see a little bit later on, even though ovarian cancer is less common, that's a big one in the news that you hear about just because some high-profile individuals have been affected by it. And as far as diagnosis, treatment, and prevention, it's a little bit stickier as compared to cervical or endometrial. And to go along with that, even though ovarian is, I think it was the 7th most common, it's the 5th most fatal, with endometrial behind that. And the discrepancy with this is there's just far more patients that are affected by endometrial cancer, and that's why it's the 6th most common cancer cause of death in women. So the incidence, this number isn't necessarily important, but I like to have patients think about 1 in 70, I think is a little bit more helpful than 1.4% or 1.5%. But it is the leading GYN cancer cause of death because of this reason right here. 3/4 of cases are detected at what we call an advanced stage. Typically by the time you have symptoms, that's already advanced disease that has spread beyond the ovary. That's where you get symptoms of abdominal pain, bloating, bowel obstruction, change in bowels, because it's mechanically pushing on other things. Once someone figures out how you can best screen for asymptomatic patients to try to detect ovarian cancer, expect a Nobel Prize, because it's going to be just that earth-shattering as far as medicine. Now, the typical age of diagnosis is a postmenopausal patient around age 63, but that's not written in stone. There's certain cell types that may have a predisposition for younger patients. When you think of a typical ovarian cancer patient like Gilda Radner, it's a postmenopausal woman. Typically, they're diagnosed and mortality follows within a couple years. There's a lot of different theories as to how this happens. This is a diagram of female anatomy. So uterus or womb here, ovary where we ovulate from to generate an egg, and then the fallopian tube, which is its transit spot to get into the uterus. There's been a lot of data in the last decade in particular that ovarian cancer may actually start here in the fallopian tube at what we call the fimbriated end, this part right here that kind of looks like hair, for lack of a better word. And that those precancerous cells actually develop into a malignancy and then kind of latch onto the ovary, which is really, really interesting. And born out of that has been recommendations that if a woman is undergoing pelvic surgery, if you're having a tubal ligation, if you're having a hysterectomy, it's recommended pretty strongly that the fallopian tubes are removed at that time in an effort to try to decrease the incidence of ovarian cancer. Now, this recommendation has just come out in the last few years, so we don't have the 10, 20, 30-year data. Is it actually making an impact? So more to come, but I guess I wanted to bring that up so that it's not a foreign concept. There's a whole bunch of other theories as to what may cause ovarian cancer. There's an incessant ovulation hypothesis where the more times that you potentially ovulate over your life, the more chance that your body could get it wrong. So thinking of it the opposite way, the fewer times you ovulate, the less likely you are to get ovarian cancer. So when do you not ovulate? When you're pregnant, when you're breastfeeding, if you're on birth control pills. So if you have more kids and you breastfeed them longer, those are two protective things against ovarian cancer. Sorry, sir. Just be glad I haven't gotten to vulvar cancer yet. Sorry. Sorry, Cindy, we're scaring away your customers. So those are a couple examples. There's certain, there may be a concern, fertility medications and kind of driving those ovaries into hyperdrive may slightly increase the risk. I think you've all probably heard about the talc issue, and Johnson & Johnson just had that big lawsuit. There's a concern that carcinogens or things that are making your body more apt to create cancer, anything that can travel up cervix through the uterus and come up here may cause issues. So another thing, interestingly enough, tubal ligation is protective against ovarian cancer because your tubes are blocked somewhere here, so any of that bad stuff like talc can't get up and cause issues. So risk factors: older age, never had a baby, possibly infertility medications. There's certain cell types that may be associated with endometriosis called clear cell cancers. That's one where it doesn't necessarily appear like the typical ovarian cancer patient. Diabetes, certain risk factors. I mean, like most things that happens in industrialized countries, particularly with a Western diet, you're going to actually see less ovarian cancer in the East Asian countries. There's your talc, decreased after tubal sterilization, maybe with aspirin, but I would say that's not a reason in and of itself to be on an aspirin. And then all the things we know we shouldn't be doing: obesity, poor diet, not enough exercise. Genetics is a really huge part. So this is one thing when we're taking a family history. If I hear a lot of breast cancer cases in a patient, particularly if the women are being diagnosed before the age of menopause, or any ovarian cancer in a first-degree relative, if any of you have family members that have been affected with ovarian cancer, they really should have genetic testing. That's kind of a new change, I would say, over the last 5 to 10 years with them looking for genetic mutations. So if it was your grandma who was diagnosed decades and decades ago, that one's a little bit stickier because, I don't think that they had all this knowledge and they certainly weren't doing all of the genetic testing. But there's certain patterns that your provider should hear to kind of say, maybe we need to look into this a little further. Maybe we need you to meet with a genetic counselor just to see if there's a potential genetic component. The most common ones that you've probably heard of are the BRCA conditions, BRCA1 and BRCA2, that also markedly increases your risk of breast cancer. But ovarian cancer risk, depending on which gene mutation you carry, can be as high as 20 to 45%. And that actually has implications for your care, even if you don't actually have cancer. And that could be a talk in and of itself, but there's risk-reducing surgeries. The 60-second overview would be being on birth control pills, in between when you're having babies, have your babies, when you're done, everything comes out, is the long and short of it. And the benefits of having an oophorectomy, or the surgical removal of the ovaries, not only decreases your risk of ovarian cancer, but also dramatically decreases your risk of breast cancer as well. So those are the other implications and why figuring out if you carry these mutations actually matters. Lynch syndrome, or hereditary non-polyposis colorectal cancer, is another one that actually carries about a 10% risk of ovarian cancer. But you may not think of that right away because most female members are going to be affected either by colorectal or uterine cancer, but a 10% incidence of ovarian cancer is also fairly high. So this is another condition where you'd want to do surgery before that there's a problem.
Can I ask a question?
Yes?
So when you say that having a screening done is good for certain people with familial tendency, what kind of screening are we talking? Is it screening of ovaries themselves, or is it looking at the BRCA1 and BRCA2?
Good question. So when I was saying screening for genetic conditions, I meant doing that genetic testing, which is typically blood work. And then if you're found to carry the mutation, then the follow-up is, thank you for catching that. That was not clear. Screening for ovarian cancer, even if you have a genetic condition, is tricky. There's nothing that's a great test. Typically, women are getting ultrasounds every 6 to 12 months and getting blood tumor markers drawn as well. But unfortunately, you're going to find more stuff that isn't cancer, But obviously if someone tells you, hey, your ultrasound's not quite normal, your blood work is a little abnormal, you're not gonna sit on it. You're gonna be like, take it out. Most of the time it's not gonna be cancer, but we don't have a great test, but that would be one of the screening modalities for ovarian. For women that are at high risk of uterine cancer, you have to see us every 6 to 12 months and get a biopsy every 6 to 12 months. So there's a lot that's involved, and that's why we work closely with our genetic counselors, because there's a lot of nuances and they're finding new gene mutations all the time. These ones are easy to talk about because, well, these are 3 big conditions, but there's a lot of nuances of new genes that they're finding all the time. And so repeat genetic testing is sometimes indicated. They sometimes give us really helpful information about, you know, this gene mutation I've never heard of, but this is what I want you to do about it. Does that kind of make sense? And so these are some potential red flags that I hear on history that makes me think, hey, we should do a little bit of a deeper dive. If you have multiple family members affected on the same side, particularly early onset, and that's a nice vague term, but typically, you know, premenopausal, if I'm hearing a lot of cases in women in their 30s and 40s, that's much more concerning than, you know, a great aunt and a great grandma who are affected at age 95. I mean, if we make it to 95, something's going to get us eventually, but those younger patients is more of a risk factor. If you have breast and ovarian cancer, or if you have multiple cancers in a particular family member, and then if you belong to an Ashkenazi Jewish ethnic group, that markedly increases your incidence to 1 in 40. Otherwise, the incidence is about 1 in 700. And then these particular cell types, and this is to distinguish from other types of ovarian cancer that typically affect young patients that are like a germ cell tumor. That's a different cell type within the ovary. All right, so there's lots of different screening tests. Again, I rely on my little calculator online, plug it in. Oh, your percentage is pretty high. Either I'll order the BRCA test myself or referral to genetic counselor. And then, as I mentioned before, depending on what the genetic mutation is, it affects care as far as medications until you're ready for surgery. And then this newer class of medications may help women as well. So typical symptoms, epithelial from the outside part of the ovary, and as I said before, typically you aren't going to get symptoms until it's a stage 3, meaning it's spread to the pelvis outside of the ovary. Abdominal girth, abdominal bloating, abdominal pain, pressure, frequency, things like that. Typically bleeding isn't going to be one of them, because bleeding more goes along with the uterus. The hard part as a clinician is these symptoms, yes, they go along with ovarian cancer, but they can go along with so many other conditions. So oftentimes patients either downplay their symptoms or, you know, sometimes as providers you kind of get tunnel vision. If you're seeing a gastroenterologist, they kind of have their little bubble of, is it reflux, is it constipation, kind of without thinking outside the box, if that makes sense. Particularly if it's a relatively recent onset and if these things are happening fairly quickly, that should sort of trigger. But truthfully, we're happy to see you anytime, if only for peace of mind. And I tell patients all the time, whether they're pregnant, whether it's a gynecology patient, you know, those nuances of those things in the back of your mind, I'm just really nervous because my friend just had uterine cancer, or I just had someone that had a miscarriage, or pick whatever the clinical condition is. If we can tell you, you don't need to worry and here's why, like peace of mind is a huge part of what we offer. So please never feel bad about, I just need you to tell me that I don't have ovarian cancer or uterine cancer, or pick whatever the clinical condition is.
What do you mean by urinary symptoms?
That can be very vague. So pressure, frequency, leaking all of a sudden, feeling like incomplete emptying, something that's just different. Now, common things being common, I'm first going to make sure you don't have a bladder infection, and 99.9% of the time it's going to be something benign like that. But if we do an exam and it's like, oh, something feels a little bit off, that would trigger an ultrasound and more of a workup. So how can we diagnose things earlier? As I alluded to before, there's no good screening test. If someone figures out a way to routinely screen, like we do with pap smears and cervical cancer, they're going to win a Nobel Prize. So I think one of the most important things is for us as clinicians is to listen to our patients and to not downplay symptoms and to address those concerns. I think being diligent on exam, I know no one like signs up for a pelvic exam. That's like not the highlight of anyone's day. That's what I tell my patients. If you came in here telling me you're excited to get a pelvic, I'm going to send you to psychiatry. Like, we got issues. But I think, you know, even if you've had a hysterectomy, even if you're not having babies, even if you don't need a pap smear, I would argue there's still a utility and seeing a gynecologist or having someone do a pelvic exam. Now, granted, this is a cancer portion of a talk, but there's other benign conditions that if we don't look, you may not be aware of, like pelvic organ prolapse, like skin changes on the external genitalia. Things that, oftentimes when I diagnose patients with some of these things, they said no one's done an exam on me in 20, 30, 40 years. I think people get scared of postmenopausal patients, or I don't know if it's a cultural thing. You think, okay, well, as a family doc, this person was like friends with my grandma, and how can I do a pelvic exam? Again, I'm not saying you have to have one every year, but there is utility to having a pelvic exam to try to catch things before they're a problem. So tumor markers, there's all sorts of fancy studies, secretions in the vagina or the blood. None of these are commercial and prime time just yet, but they're always working on things. So I know this kind of portion of the talk sounds a lot of gloom and doom, but I think that there are some encouraging things on the horizon. So I don't want people to lose sleep about ovarian cancer. We talked about that, symptoms, maybe aspirin, birth control, if you're not having babies. And you're gonna hear this theme, don't smoke, eat healthy, and exercise, both the easiest and the hardest thing that we're gonna tell you tonight. Okay, endometrial or uterine cancer. This is the most common gynecological malignancy. I feel like that incidence is probably a little bit higher depending on particular risk factors. It's the 4th to 5th most common cancer of women, and it's increasing in incidence. And why is that? Well, a lot of risk factors for type 1 uterine cancer are obesity, being postmenopausal, having high blood pressure, having diabetes. And I find this last bullet point the most interesting. Typically, it's diagnosed in a postmenopausal patient, but we're seeing more patients that are either premenopausal or perimenopausal that are developing this condition. And so there's a whole host of clinical criteria on who should come in to be evaluated. Again, that's why your women's health provider would go through some of these things. But general risk factors, so obesity, high blood pressure, diabetes, I think these are kind of co-founders. One may cause the other. Never having had babies, going into menopause late, early menarche, or basically the more periods you have, the more hormonal stimulation of the uterus. Anovulation, so particularly in women with polycystic ovarian syndrome. Basically, in a Cliff Notes version, estrogen feeds the lining of the uterus and increases the risk of uterine precancer and cancer, and progesterone puts the brakes on. And all of these are conditions where you have relative more estrogen as compared to progesterone. Tamoxifen is used for breast cancer treatment or breast cancer risk reduction, and that's associated with both benign and malignant changes in the uterus. And so Jill is somewhere in the back as our oncology representative and our oncology nurse coordinator. So the reason I'm bringing Jill into this is as part of the oncology coordination care. I think this is the importance of multidisciplinary care, that hopefully you're being counseled, hey, do you still have a uterus? These are the things I want you to watch out for, and this is why you need to see a gynecologist right away if you're on this medication. And then as we talked about before, Lynch syndrome increases the risk of colorectal and ovarian cancer, but the risk of uterine cancer is nearly as high as that of colon cancer. And I think that's a really important thing to note, because if everyone in your family has colon cancer, obviously that's going to be at the forefront, but we don't want to forget that your risk of uterine cancer is nearly as high. Most women are going to present with bleeding, abnormal bleeding or postmenopausal bleeding, and I tell all my patients if they're postmenopausal, you're 70 years old, you went through menopause 20 years ago, there's no one last hurrah, one last period, even though your granddaughter was at your house. That would not be normal, and you should seek care. Unless there's an obvious explanation, like you were shaving and cut yourself, oh yeah, it's external or whatnot. But I guess that's my public service announcement for the night, is if there's any bleeding, come in. It's unlikely. I think of all patients who present with postmenopausal bleeding, it's 5 to 7% have cancer. There's a whole host of benign conditions that are the more likely cause, but I tell my patients, it's my job to prove to both of us that there's not a cancer that we're missing. In premenopausal women, any weird bleeding, and I tell patients that's really loosely defined. Heavier periods, lighter periods, shorter periods, longer periods. I mean, anything that's weird, particularly in women over the age of 45, or women that are younger, especially if they have PCOS or certain hormonal conditions. If you see these particular kinds of cells on a pap smear, particularly in someone who's postmenopausal, that should trigger an additional evaluation, and then other things on your pap smear report that The details aren't important, but suffice it to say, once in a while you can pick it up there. Most women are going to have bleeding though. The good news is this should be our highlight slide. So if it's a stage 1, which is limited just to the uterus, the survival is 95%. It starts to go down as things spread a little bit further. I would say, about 70-75% are diagnosed at stage 1. I would say that's the positive. And most of the time, the pep talk that I'm giving to my patients is, out of all of the gynecological cancers, if you're going to pick one to get, most of the time endometrial is the one to choose, because as far as prognosis, treatment, most of the time it is treated solely with just surgery without chemotherapy or radiation needed. All right, so we talked about this, some nuances. How do we evaluate? That kind of depends on your provider and their style. Usually I try to do everything in one visit. Typically that would be an exam, do a pap smear, do this fun thing called an endometrial biopsy. That's all stuff we can do in the office same day. We do try to get patients an ultrasound ahead of time. That's one of the benefits of our menopause centers. We try to make this as smooth and seamless as possible so we can go through all of those details and try to have at least a diagnostic plan that day so you're not left worrying and waiting, if that makes sense. So this is trying to make the argument. So let's say you do this little thing in the office. We call you back, hey, it's fine. And we're like, yay, that's great. It's saying a quarter of patients with an actual uterine cancer have been told they've had a benign biopsy or DNC. That seems a little bit high. How does that actually happen? I think we're falsely reassured based on what happens with patients. So common sense should prevail. If someone keeps coming in to see me, even though if I've done a workup, I'm still having heavy bleeding. You last saw me 3-6 months ago, there comes a point where you have to say, okay, you're 70, this is not normal, that thing's gotta come out. So again, I think this is the important part of being an advocate for your own health. If your gut's telling you something's not right, even if you have someone that's trying to reassure you, oh, the ultrasound looks fine, oh, you had a biopsy, I think that it's okay to push the issue, and if I'm the person saying it's fine, hey, I was at your talk at the brewery when you scared the people away, you said it wasn't fine. All right, so this is kind of a sobering slide. 3 in 5 cases, 60%, can be prevented by being normal body weight and exercising. So again, both the good news and the bad news. This one is kind of the wah-wah part of the talk. This one doesn't get a lot of press because it's not as common. It's just not a fun one. So if nothing I'm saying makes sense about this one, please feel free to interrupt. So the vulva or vulvar cancer, and I guess I shouldn't assume. So the vulva refers to the external genitalia, the labia, the mons pubis, and the skin of the external genitalia. Sometimes I've gone through a whole hour visit with patients and they're nodding, and then at the end they're like, so where's the vulva? I'm like, oh, I should have taken a step back. I don't recommend Googling it. It's bad. I tried that once. I was like, never mind, don't Google it. Here's a handout. Yeah, I learned that the hard way, so don't Google. So external genitalia, in your mind, I want you to kind of think vulvar cancer shares a lot of risk factors with cervical cancer. And the reason for that is both of them are typically HPV mediated, HPV being human papilloma virus. So it's just a different manifestation of where this virus can cause trouble. So it does share a lot of those risk factors. So it's a very rare cancer, again, a disease of postmenopausal patient. It's getting a little bit better in older patients, but rising in younger patients. I think that's a couple reasons why. We're doing a good job in screening with cervical cancers and treating early stage problems with the cervix. And sometimes we forget that those patients also have vulvar issues, or there's certain patient populations where you're seeing smoking, high-risk sexual behavior, things like that on the rise. So major risk factors include history of HPV infection. So that would include, if you have problems with your pap smears, just in the back of your mind, think, okay, if I have any weird symptoms on the external genitalia, I remember Kramer had that one talk, maybe I should get that checked out. Patients who smoke, any sort of chronic irritation, so certain skin conditions, obesity, hypertension, diabetes. I mean, we put poor hygiene on there, but we're talking mostly poor access to clean water, patients that are in particularly socioeconomic areas or different countries, things like that. There is a thought that there's possibly 2 different diseases based on the cell type and how these patients present. Oh, it's typically diagnosed at a late stage because patients sit on their symptoms, or Providers don't do what they're supposed to do. You say that you're itchy and having bleeding, spotting pain. Oh, it's probably a yeast infection. Here's your yeast med. Off you go and you forget about it. Again, the plea to have someone do an exam. And if I'm ever working with students, medical students, you know, everyone gets nervous about doing the speculum exam because you don't want to mess it up, and I need to know how to do a pap smear. I remember this slide from medical school and it kind of stuck with me. This old, like 80-year-old guy, don't forget to look at the vulva. Don't just rush in there. And I was like, oh, okay, good point. I know. We're all like, okay, don't forget to look at the vulva. But that's really true. When you're doing a full GYN exam, I mean, a thorough part would also be looking at the external genitalia. And I always tell patients, my rule of thumb is sort of like Sesame Street. If one of these things doesn't look like the other, if there's any skin discoloration, texture, things like that, that should prompt a biopsy or at least a deeper look to make sure we're not missing anything. Does that kind of make sense? I know you're all like, that sounds really fun. Let's have someone biopsy my vulva. I'm coming to see you. I'm not going to sugarcoat it. I mean, we do them a lot. Patients they do a good job, but you know, it's one of those things like, man, I do this for a living and I think you'd have to like sedate me or I don't know, something. So how might a vulvar cancer or precancer present? Vague symptoms. It can be kind of a focal spot of irritation, something that's itching, something that's burning. Itching is probably the most common. By the time you actually have a lump, a bump that's having discharge or bleeding, we're probably going to be concerned. This is no longer a precancerous lesion. This is more likely a cancer. It looks different. It can be black, it can be white, it can be brown, it can be raised, it can look like a wart. That would be another thing, you know, unless you've decided to get wild and crazy in your postmenopausal years and like take up prostitution or IV drug use. New onset genital warts is probably like that. Don't just say, oh yeah, I got some new warts from my new boyfriend. Like, you should probably see someone because that would be not as common in a postmenopausal patient, particularly if they fail treatment. Oh, the prognosis is okay if your nodes are not affected, so 90% that's pretty good, but you can see it drop dramatically with the more lymph nodes you have affected. This is not a nice surgery that you would ever want to wish on your worst enemy. I'll spare you the details. It's just, this is not a nice disease. Not that the other ones were super fun, but this is just not, it's not a nice disease. It's not an easy recovery, which is why we want to catch things at the precancer stage. So this is code word for things that are kind of precancers or dysplasia before they've gotten bad and before you have to do things that are a yucky surgery, suffice it to say. So I guess this is our, again, being an advocate. Don't settle for, oh, it's a yeast infection, even though it's been going on for 6 months. If you're treated for one, you know, I don't think it's unreasonable to tell someone your symptoms. We assume, okay, yeah, you're in a hurry, maybe you got to go to work. Try this for your yeast infection. If it doesn't get better, like that should prompt a visit and insist on an exam. If something doesn't seem right to you, trust your gut, listen to your body, and see a doctor that's going to listen to those concerns. A reminder to us to not just rush to the pap smear, like look at the vulva, like that 80-year-old doctor said. Biopsy anything that looks suspicious. And so, you know, I guess this would be another thing. We're not looking to do procedures just for fun. Like, I don't want to do a vulvar biopsy to someone, but I feel like it's important for everybody's peace of mind. Okay, we're not dealing with a precancer or cancer, so we can work on treating the irritation in different ways. And then treatments for these precancerous stages, there's certain creams that we have that are immune modulators. There's laser therapy where you can actually burn off some of the atypical lesions. Some of them require surgical excision, but that's a small outpatient procedure, so you can go home the same day. And again, if you catch them and get rid of them in the precancer stage, with close monitoring, it'll never develop into a frank cancer to cause problems. This one, I mean, I think this is good in theory, but it requires some creative yoga type stuff and a really big mirror to like contort yourself in a way to do a vulvar exam. I mean, we say that and I'm like, I know what I'm looking for and I don't think I could do that. So that's good in theory, and I don't really think anyone was gonna want like their friend to help them take a look. So I think good in theory, execution, I'm not really sure how that might happen. Just be aware of your body. If something doesn't seem quite right, hey, this feels like a weird mass, lesion, something like that, come in and be seen. Make sure your clinician is doing a thorough exam. HPV vaccine, if you're under the age of 45, it has FDA approval through women in age 45. Don't smoke. Safer sexual practices, I mean, yes, we're supposed to tell everybody that, The one kind of wah thing about HPV is even consistent condom use does not prevent transmission 100% of the time. And I think that's something that people don't know, or we don't do a good job telling women, because HPV can kind of affect anywhere where you sit on a chair. I mean, that's the whole skin area that can be affected by HPV. You don't really have a condom for that whole area. So choose your partners wisely. Those other disease processes, improved hygiene or listening to your body if you have skin irritation should prompt a visit. Even women who may have had a stroke or in a nursing home are completely incontinent. That doesn't mean, oh, they have a depends, they have irritation, bleeding. Good luck, grandma. I mean, there's things we can do for quality of life to decrease chronic inflammation there. We didn't really talk about cervical cancer as far as a bullet point and slide, but suffice it to say a lot of the risk factors are similar to vulvar cancer. Most women are aware that pap smears are designed to be a good screening test, and that's one of the few major success stories as far as a cancer screening test that has dramatically improved cancer diagnosis. If I was going to put a slide together, I guess I would say most women, now I say that with my air quotes, after the age of 65, low-risk patients no longer require screening cervical cytology or screening pap smears. But there's a whole list of criteria you need to meet in order to be that low-risk patient. You can't have had a history of high-grade precancer, code word CIN 2 to 3, in the last 20 years. So if you had shenanigans or you had to have all these procedures in your 50s, that means we're pushing things into your 70s for screening. You can't be immunosuppressed. So certain autoimmune conditions require methotrexate or other antibiologics. You fall out of that category and you should still be getting annual pap smears. Certain women, even if you've had a hysterectomy, that's not necessarily curative. You may still need to be followed with pap smears of the top of the vagina. So, I mean, yes, as a generalization, most women don't need pap smears beyond age 65, but that's not applicable to every patient. And then you also need more recent pap smears. So if you haven't seen anyone, or I don't have documentation of one in the last decade, unfortunately, you're going to probably get a pap smear as well. So as if that wasn't kind of the taking it down to a low, we talked about obesity, we've talked about hot flashes, vaginal dryness, and now gynecological cancers. We need to get a more peppy, upbeat part of the talk. Any questions on this one? Or you guys just want to go to the bar? More beer?